I'd like to introduce Dr. Errol Colak, who is a consultant in radiology at St. Michael's Hospital. He's going to go over some of the interesting elements in this X-ray and in this clinical presentation.
Hello everyone. We're going to discuss both an approach to this X-ray and then come up with a diagnosis for this patient. So here we have a frontal radiograph in a 24-year-old male who presents with shortness of breath. The first thing to assess when reviewing a plain radiograph of the chest is, first of all, is this the right examination on the right patient performed on the data of interest? And then we also evaluate it for technical factors such as, is the penetration sufficient enough? And did the patient take a sufficiently good breath? So in this patient, we have a radiograph with good respiratory effort. It is more or less a technically sufficient study. In approaching the chest radiograph, it's important to have a consistent step-by-step approach to ensure that everything's covered. Personally, I like to start in the midline and look at the trachea. Is the trachea in the midline or is it deviated to one side or another? And can we see it throughout its entire length without any evidence of a gross mass? In this case, the trachea is in the midline. Then I move on to look at the mediastinum and heart. Is the heart occupying less than 55% of the thoracic volume? If it is, heart size is normal. And if it's greater than 55%, then there's an element of cardiomegaly. Then I go on to see if there's any abnormal soft tissue within the superior mediastinum. And then I look at the hyla to make sure they're not enlarged and that there's no hylar lymphadenopathy. Then I proceed to look at the lungs. Has there been a sufficiently large breath? To do that, I look to see whether or not there are 8 ribs that we see posteriorly, and in this case we do. Then we go on to see if there's any lung consolidation, any nodularity, or any abnormal interstitial markings. In this case, the lung parenchyma is absolutely normal. Then we move on to the pleural surfaces. So we run along the entire pleural surfaces, along the diaphragm and along the lateral thoracic walls, looking for any abnormal thickening or the accumulation of fluid. And in this case, the pleural surfaces are clear. Then we move on to look at the bony structure of the thorax. We start off by the spine, and we look to see that all the vertebral bodies have a normal height. Then we see 2 spinous processes. Two pedicles, a spinous process, and 2 transverse processes. Then we should go on and make sure that all the ribs are normal, that there's no destructive osseous lesion or any areas of sclerosis. Look at the clavicles, sternum, and shoulders. In this case, the osseous structure of the thorax are grossly normal. Then we look at the soft tissues of both the lateral chest and also the neck. And lastly, we look at the upper abdomen to ensure that there's no free air under the hemidiaphragms. So just to summarize the findings on this case, the trachea is midline, heart size is normal, the lung parenchyma is clear, there are no pleural effusions, and the soft tissues and osseous structures of the thorax are normal. So overall, my impression is that we have a normal chest radiograph in this patient who presents with acute shortness of breath.
Okay, thank you very much for that summary, Dr. Colak.